I'm Andrew Schwartz, and you're listening to The Truth of the Matter, a podcast by CSIS where we break down the top policy issues of the day and talk with the people that can help us best understand what's really going on. To get to the truth of the matter about the recent outbreak of monkeypox in Africa and other places, we have with us Dr. Steve Morrison, my amazing colleague who heads our Global Health Policy Center, who many of you will remember that Steve and I hosted the coronavirus crisis update during the pandemic. Steve, welcome to the podcast as always.
Thanks, Andrew. It's a great pleasure to be here with you.
All right, Steve. So the World Health Organization recently declared the ongoing monkeypox outbreak a global health emergency. But I want to back up for a minute and let's remind our listeners, what exactly is monkeypox?
Monkeypox is a virus in the pox family. So that includes smallpox. Monkeypox is a misnomer. It was first discovered in 1958 in Denmark. And it was a case of monkeys that were being raised for laboratory use in Denmark who were exposed to rodents that had come from Africa. And most of the time in the wilds of Central and West Africa, in the deep forests, the virus is carried by rodents. And so it was misnamed monkeypox in 1958 because it was the monkeys that were infected by the rodents.
I see.
And just as a peculiar little other side story, there was another case in 2003 in the United States in which these enormous Gambian pouch rats that are like a meter long. They're like the largest rats in the world, and they're very smart and they're tameable. And there are certain people who have them as pets.
In the United States?
In the United States. And so they were being...
It doesn't sound like a great pet, I have to say.
So those Gambian rats were imported into the United States by pet store operation, and they were being in a holding facility, and they were in the presence of prairie dogs, which are also pets. And the prairie dogs got
So people keep these rats as pets?
Yeah.
Okay.
Apparently, the people that like people who are fond of these particular animals are very fond of them, and so there's a market.
Okay.
And there's a market for prairie dogs.
And it's legal to bring these here to the United States, apparently.
Yeah, and we didn't know at the time that they were going to be carrying the pox, the Mpox. So the prairie dogs were infected because they were they were in the same facility. The prairie dogs got infected, and the prairie dogs were sold to clients around the country, and 72 Americans got Mpox in 2003. But they recovered, and they were fine. And it was the clade 2 version, which I'll get more into that. But so it was discovered in 1958. The first human case was 1970. And over the last 50 years or more, Mpox has been seen as a low-grade viral outbreak that doesn't spread much. And when it has affected human beings in Central and West Africa, in the deep forests, it's usually been initiated from an animal species. To the degree that humans have gotten it, they've gotten it through eating bushmeat or coming upon a dead animal and being contaminated. But usually it was in remote areas. It was small populations affected. There was very little in the way of diagnostics or surveillance. These were, deep forests in Central Africa. And it would disappear. It would peter out. It would burn out. And so every few years you'd see an outbreak, but people didn't see this as human to human. They didn't see it as all that dangerous, but you'd see it reported. And they changed the name just a few years ago because people said, wait a second, that plays to tropes, racist tropes.
So this is why we call it Mpox.
So now it's been called, they changed the name in 2022 when we had a big outbreak in Europe and the United States among gay men who have sex with men. And that triggered a reassessment. And so there was a period where they said, we're going to call it Mpox. So for a 1-year period, there was a transition. People were calling it both monkeypox and Mpox, but now it's called Mpox. But the point is that it's been around for a long time, and it's been regarded as something that's low grade and not all that dangerous. Now, what has happened to change the picture where we're now back in a second emergency? We had an emergency created, a global emergency declared by WHO in 2022 when we had the outbreak within the gay community, MSM community.
And was it deadly then?
Well, it killed, in the United States, it killed 58 people, but in 30,000 cases. There were globally 100,000 cases in 2022 and about 200 deaths, just under 200 deaths. So the clade 2, that was the clade 2. Clade is a term about a clustering of genetic types. The clade 2 had very, very low mortality, 0.2% mortality, right? But it was dangerous. And in that clade 2 outbreak, the World Health Organization intervened and declared in May of 2022 that it was an emergency, a global emergency. And then it in July of 2023, it said the emergency is over. What happened in the meantime was you had 100,000 cases, but you had, and these were in these large festivals like the Canary Islands and another location in Europe where there were large gay male festivals with, tens of thousands of people. And we had some similar outbreaks in the United States. But what happened was the public health communities got mobilized and they used a lot of the tricks developed during HIV in terms of behavior modification and lowering risk. And that was the single biggest thing in bringing the case count down, along with introducing vaccines. So there was some delays, but by 2023, the numbers in the United States had dropped from 30,000 a year to 1,700 last year. And so the emergency was declared over. So that's the background to where we are right now. So what happened to change the Africa version, which is called Clade 1 versus the Clade 2 that affected the gay population in 2022? What happened is to make it more dangerous and to suddenly have, in the space of this year alone, 17,500 cases and several thousand dead.
This is globally?
No, within Africa.
Within Africa, okay.
Within Africa, we have a very serious outbreak. It's centered in eastern Congo, in the South and North Kivu, and in Equator province. So it's in an area of the world that is extremely disrupted and unstable, with lots of different armed elements running around. It's a high density of population, a high density of refugees, and a total breakdown of health services and the like, and multiple other threats. It has Ebola, recurrent Ebola, it has measles, cholera, Lassa fever, and the like. And that's where it started surging this year. Now, what's at play? What has happened? Because it's been in Africa since the 50s that we know, and it was just a low-grade thing that would come in, and it was all zoonotic origin, affecting very few people. It was very slow. It was very slow transmission. Now you have really fast transmission that's killing people. So what happened?
And who is it killing? Is it killing everybody? Is it killing children?
I'll get to that in a minute. So let me just emphasize the things that changed. Remember smallpox, right? Smallpox was eliminated in 1980 from the world. When people were getting vaccinated against smallpox, you got the added benefit of vaccination against monkeypox, or what we now call Mpox. Mm-hmm. Okay? You didn't know that, but if you were in Africa and you were exposed to Mpox and you had been vaccinated against smallpox, you were not going to get sick, right? So smallpox is eliminated in 1980 and the vaccination campaigns end. And so a few years later, the last smallpox vaccination in the United States was 1972. The last smallpox vaccination in the Africa zone, where these in Central and West Africa, was 36 years ago. So you have a population now that has, if you're 36 or younger, you have no protection at all.
Because you were never vaccinated for smallpox.
You were never vaccinated, so you're much more vulnerable. So that's the first factor. Second factor is mutation.
Yeah, I was going to ask you, okay, so what are the symptoms of this and how does it mutate?
Okay, so viruses mutate, right? Sometimes it's inconsequential, but in this case, it has mutated what you might think of it as the Omicron moment for Mpox, right? Like when COVID-19 hit the Omicron moment, it just boom,
blasted out.
So this is the Omicron moment for Mpox.
Okay, so that's how serious this is.
Yeah, so the clade 1b is the dangerous one. I told you earlier that the clade 2 that was affecting the gay population had very low mortality, 0.2%. The mortality of clade 1b is somewhere between 3 and 4%.
That's significant.
That is many, many, many times higher than 0.2%.
That's right.
3 to 4%. And it's transmitted sexually from human to human. There can be transmission from zoonotic sources. You can still have proximity to animals or consumption of bushmeat. You can still get it that way. But now it's become endemic where you have human-to-human transmission sexually, and that can be through heterosexual behavior. This is the first time we've had heterosexual transmission. It can be through men having sex with men, and it can be it's now what we're seeing is a household transmission.
Yeah, that's what I was going to say, because earlier I said, is this now affecting children? I have read some reports that actually, indeed, it is now affecting children who are not getting it through sexually transmitted diseases, of course.
Correct. What's happening is that adults are getting it, acquiring it, and then there's household transmission from parent to a child because you're living in very close quarters. You have contaminated linen. You have any number of manner in which this can be
you're taking care of your kids when they're sick,
right,
you know,
right.
I mean, sure.
And then so the children are picking it up, and then the children are taking it to school, and there's transmission child to child. So, this is looking very much like HIV on steroids. I mean, it's a sexually transmitted.
But it's different though. If children are transmitting to children, obviously not through sexual contact, through regular contact. This is much more spreadable, it seems like.
Yes, exactly. And the other thing I'd say is that it's embedded within the sex worker community. And the area where this is coming out of is not only a dense with refugees, dense with warfare, a collapsed, broken down, lawless place with no health services or surveillance, many other rampant dangerous diseases, but you also have heavy-duty mining sector. So there's lots of migrant miners, and with migrant miners come brothels and prostitutes. And so it's become embedded within the sex worker community. So those are the main things that have just taken this off. And what have we seen is Eastern DRC is the perfect mixing bowl for all of this, right? When you add in the mayhem and the other factors, right? Measles, Lassa, insecurity, crowding, refugees, prostitution, miner communities. And you've got all this other stuff going on, and it's impossible to take samples. There's no surveillance, and it's too insecure. The only way in which they're beginning to detect it is when people do get sick and do find a health provider and they get diagnosed in a clinical setting. But what this all means is that we, the world, Congolese, others have been exceedingly slow to recognize this. They've been blinded to it by all of these circumstances I've described. People have been calling attention to this for the better part of this year, but meeting a lot of resistance from the DRC government has been very, very slow to take this seriously and prioritize it. Africa CDC has been very slow to take this up. WHO has been very slow to take it up. So it's now racing out in front of us and spreading regionally. So you see clade 1b now in Rwanda, Burundi, Kenya, and Uganda. So the four of the neighboring countries, and you're seeing it in large cities. I said earlier, this was something that was way in the deep forest or in the small rural communities. Well, Goma's 2 million people. It's endemic now in Goma. Bukavu is 1 million people. It's endemic in Bukavu. These places have international airports. They have highways. Even though they're at war, there's constant flow of people. And guess what? It's now it's now taking root in the four neighboring countries.
Okay, so what are some of the symptoms you get when you get monkeypox?
Okay, the other thing I want to, yes, that's a great question. So you get monkeypox and you have flu-like symptoms in the early part. So you have a little respiratory, you have aches and pains, and then you develop sores and lesions. And usually if it's a case that, you get sick and you recover fine, it's 3 to 4 weeks. You may not know that you even have Mpox. You may just think I've got something else. But
you might think you have COVID if you don't have the lesions, I guess.
Yeah. So clade 1 is transmitted asymptomatically, which is a very important factor. And the conditions are less severe than clade 2. So people are less alarmed by this. The other thing I want to emphasize, and this is true in Nigeria and West Africa, where you've got clade 2 and it's principally in the gay population, the stigma attached to men having sex with men is huge in these societies. And so, it's outlawed in Nigeria. So you can't even begin to talk openly about the means of transmission and the communities that need to be reached. That operates against you as well. So back to who's threatened the most, right? The populations that are threatened the most are children. 2/3 of the deaths that we've seen so far are under 15 years of age.
So tragic.
So children are very, very vulnerable. Those living with HIV are very vulnerable. And we have only a couple of very early small studies that show that up to 10% of that population can die from clade 1b. Because you have today in the world 40 million people living with HIV. 10 million of those 40 million don't know their status and are not on therapy, on antiretroviral therapy. And even if you're on antiretroviral therapy, clade 1, you don't want to run into clade 1b. And we don't fully understand the interplay and how vaccines work in that population and the like. But 3/4 of the population of that 40 million is in Africa. So if we uncork this, and it's now in 12 other, Mpox is now in 12 other countries in Africa, and along with DRC, and it's in 26 countries in total.
So it's now outside of Africa as well, which is why, back to the original thing, WHO has declared this a global health emergency.
Right. And that gets back to, we have multiple parallel epidemics happening here, right? We have what I've just described, which is clade 1b, new form, dangerous, coming out of East DRC and spreading. But you also have the clade 2 outbreak, which is principally within certain sexual communities, right? Men having sex with men. And that's West Africa, but it's also like the cases that we've seen in South Africa are clade 2. But it's in 12 other countries in Africa, and it's in 26 countries, including, Philippines, Pakistan. We had the first case of clade 1b imported into Sweden from Africa, which gets to a point I want to leave you with, which is that it's going to come here. We're going to see clade 1b. We're going to see clade 1b here in the United States.
If it's in Sweden, it's going to come here.
Yeah, it's going to come here. It's going to come to Europe and Asia and Latin America, and we're going to be. The question is going to be, how much panic and hysteria will we see? You remember during Ebola, almost exactly 10 years ago today, was when Frieden was out in West Africa in the 3 countries that
Tom Frieden, former head of the CDC.
As head of CDC. Samantha Power was out 10 years ago in Liberia, Sierra Leone, and Guinea, the 3 countries.
She was then the UN ambassador.
She was the UN ambassador. She was out circulating. Frieden was out circulating. Head of WHO declared a public health emergency August 9th. They went as Samantha and Tom went out and came back, and Frieden was banging on the door of the White House saying, this is a complete catastrophe, and we have got to acknowledge this. President Ellen Sirleaf Johnson sent her defense minister to the White House with a note to President Obama saying,
President Johnson of Liberia.
President Johnson of Liberia sent a letter saying, we're about to collapse. You got to do something. And President Obama on September 16th of 2014 went to CDC and declared, for the first time ever, we're going to send troops to Liberia to crack this panic and cycle and open the air routes and supply routes and help lead the response. Now, a couple of weeks after that was when we had the cases introduced into the United States. There were only 11 cases of Ebola introduced into the United States.
But they sure were scary.
2 deaths. And you remember how unbelievable the hysteria was.
Unbelievable. You did a documentary on it.
Yes. And guess who, in that documentary, which we put out in 2015, around the hysteria, one of the theses in that documentary was that the hysteria went through the ceiling when Trump stepped in. He hadn't even declared his candidacy yet, but he stepped in and said, why are we letting any of these people who were working for the NGOs in West Africa in the response back into this country? They should be barred. When the doctor, the medical doctor, was brought back to the level 3, the emergency high containment hospital in Emory to save his life, there was objections and this sort of thing, and the hysteria and the sort of 24/7 stuff, which gets me to this point. If it's introduced soon in the middle of our electoral cycle, how is that going to be understood and how is that going to be consumed, right?
Interesting.
It's the 10th anniversary. We're going to see some dangerous and frightening thing introduced in the United States. And people it will be in the midst of a very tense and combative toxic electoral environment. And we just need to think ahead about that.
So we're not just dealing with an epidemic and maybe a pandemic at some point, hopefully not. We're dealing with something that could politicize the country as well, is what you're saying.
Yeah. And be seized upon to try to discredit, the administration. So where are we right now? There's been a 3-fold expansion of cases in Africa of the clade 1B. In 2024, 17,500 cases, over 1,000 dead, and it's continuing to rise. When you talk to the experts who are working on this stuff, they're cautious. When you say, okay, what's the trajectory going to look like, right? They're like, we don't know. We've never been in this situation. It could crash. Ebola went like crazy up through November, and then it crashed. And so people are, but the experts.
When you say crashed, you mean burned out, like no longer existing.
Yeah, people change their behavior. Even before you had the treatment centers, that were put in place didn't stop the outbreak. It was terror. It was people seeing all of their family members dying around them, and they changed their behavior. They changed the burial practices. They changed all sorts of behavior, and it brought it down. And even though you look at Eastern Congo and you say, oh, that's an impossible place to ever imagine anything can be done there. Well, they had a really severe Ebola outbreak in August of 2018. It took 2 years to bring it under control, but Tedros was there 13, 14 times, the Director General of WHO. CDC, Africa CDC has won permission today to put 10,000 healthcare workers on the ground in the zone.
To hopefully prevent it from spreading.
Yeah, they need to get a workforce in place that can do the detection and the surveillance and the care, and they won permission today to do that. And they're going to have to provide them with housing, support, security, and there's got to be antivirals and vaccines, and there's got to be people prepared to pay for them and place the orders, and there's got to be regulatory pathways that don't yet exist. So it's going to be the response this fall in Africa is going to unfold on a crash basis, but it's going to be complicated and difficult, and it's not going to be fast. It's going to be, we're going to be sitting around waiting for vaccines to get to where they need to go with a plan of action for how they're going to be executed. We're going to be waiting for a while, and there's enormous pressure. The declarations from last week, the WHO declaration on the 15th of a global emergency and the Africa CDC declaration the day before of a regional Africa emergency. Those are big alarms, right? They're a big signal. They'll be useful at focusing attention.
They make people think this is the next pandemic coming.
Right. Political will, resources, and the like. But it doesn't happen magically. And, the U.S. is going to play a very important role here.
Yeah, I was going to say, Steve, obviously we're a bipartisan organization and we try to bring everybody together on these issues for the sake of good policy. What does the administration, the current administration, and then of course the next administration need to do to address this so this isn't a problem here in the United States?
Well, CDC has already, going back to very early in this year, they've repeatedly issued very public guidance saying we need to prepare for the possibility of the introduction of this clade 1B into the United States. So the signal's gone out to public health authorities at the state, local levels, to clinicians and others. Keep your eyes open because this is going to appear. Familiarize yourself. Read this. Be aware that we're going to be at risk. CDC's been pretty forward-leaning and early and proactive.
Telling everyone this is coming.
Yeah, and then that started early this year, and then there's been two big things that they've done. CDC is providing technical support to Africa CDC, which is very important, and they are scrambling to make additional purchases for our national stockpile of both the antivirals and the vaccines. They put big orders in. And like with COVID, there'll be pressures. Got to meet the domestic need. There's 2 million American men who have sex with men, 2 million in that population who will need to be protected in this period of a resurgence of the clade 2 outbreak in the United States. And during 2022, only a quarter of those who were vaccinated took the second vaccine. And so there's a vulnerability there. So we need vaccines, we need antivirals, we need far better tests for our own population, and that'll be the top priority. But in terms of dealing with Africa, the administration is looking at a bunch of options. They've offered 50,000 doses of the Bavarian Nordic Jynneos vaccine. The Congolese have been very slow to accept that. But I think what we're likely to see is, and we'll be talking to the White House about this, so I think we're going to see a higher order of response. And what I mean by that is there will be more visible leadership and coordination. I don't know if they're going to appoint someone to take it on or whether they'll use the talent they have at the NSC and in our agencies. But there will be a higher order response. I think they'll make a bigger scaled commitment on the vaccine side of things and a commitment on the diagnostic, improving and delivering. There's a huge gap in the diagnostics. If you can't figure out who's got what in this setting, you don't know who to vaccinate.
Right. And we're not at a point where our government is saying that Americans need to go out and get vaccinated preemptively. Nowhere near that.
No, they are focusing on the most vulnerable population here in the United States.
Got it.
And I think we will expand. We're already supporting Africa CDC with people, with technical support, with equipment, money. We can do more as they ramp this up. We can do more. So I'm hopeful. I think Bavarian Nordic has a vaccine that's effective against both clades. They've announced that if there are orders, they've got about 500,000 units of the vaccine available. They made some commitments along with BARDA and HERA in Europe to bring them to DRC and to the Africa CDC. But they've said if the orders come through, they can do 2 million total by the end of the calendar year and ramp up to 10 million in the course of 2025, which is what's estimated as the need. But there has to be a regulatory pathway. There has to be financing. There have to be orders placed. And some of the other institutions that are key to this, like the Gavi Alliance, CEPI, UNICEF, are going to be at the table, and they're going to be out there working this.
Steve, thanks for helping us begin to understand this. Hopefully the outbreak is contained and we don't have to come back and talk about this. But I suspect from what you're saying, we will be talking about this in the months to come.
I think it's going to be a struggle. I think we've got a lot of tools. I think the containment within the United States, I think we're in reasonably good shape. There is a resurgence we're seeing. It's not as radical as what we're seeing in Africa. The numbers are bumping up. And so there's a need to double down, and we know what to do, and the behavioral changes, and we can, so I'm hopeful there. I think I am worried about the Clade 1 getting introduced here and inducing panic and political manipulations of that, as we saw during Ebola. On the Africa side, it's a much bigger problem and more complicated, but there are pathways. But it's going to take a while, I think. And there's so much we don't know. The trajectory of this outbreak, but also there's some of the transmission patterns. When we're talking about all the kids, the people are like amazed that 3/4 of these cases are children. And we also don't know if it spreads into populations where there's a high volume of folks living with HIV and the mortality gets to those very high levels. That has people very frightened.
Well, Steve, thank you very much for your insight on this. A lot to think about here.
Thank you. Thanks so much.
If you enjoyed this podcast, check out our larger suite of CSIS podcasts. From Into Africa, The Asia Chessboard, China Power, AIDS 2020, The Trade Guys, Smart Women, Smart Power, and more. You can listen to them all on major streaming platforms like iTunes and Spotify. Visit csis.org/podcasts to see our full catalog